Hi, everyone. Welcome to the 2023 ICS Research Forum, Way Forward, Advancing Health Equity Through Data. We're going to start the morning with a land acknowledgement. I am today in Toronto, Ontario, but as I make my land acknowledgement, I would invite each of you to reflect on the land where you're located and think of the Indigenous peoples that are on those lands and make your own appropriate acknowledgement. Toronto comes from the Mohawk word tikaronto, which means place in the waters where the trees stand. I want to acknowledge and honor the fact that where I am today are the ancestral lands of the Mississaugas of the New Credit, the Haudenosaunee, the Chippewa, the Anishinaabe, the Huron-Wendat, and that today many other First Nations, Métis, and Inuit people continue to call Tikaronto home. And we thank them for sharing the land with us. Next, I'm delighted to introduce a friend of ICS, Elder Wendy Phillips, who will lead us in an opening prayer and help us set our intention for today's important conversations. Wendy Phillips is of the Bald Eagle Clan, a Potawatomi and Ojibwa, and a proud member of the Wasauksing First Nation. She's a graduate of Trent University, Fleming College, and George Brown College, and she's a founding member of the Indigenous Innovation Initiative. Over to you, Wendy.
Thank you. I apologize. I had a bit of sound difficulty, so say good morning, bonjour, and I'll begin this opening in our language. So bonjour, megzi dodem, awiro kaza bejgot ndishnkaz, wasauksing na dunji, giwain zibi na dunjaba, jaman mak ge podwad min down. Chimigwach kanage go gajak tolt, chimigwach nishangij gat. Chimigwach Atsokanak. Chimigwach Wabanomado, Jawanomado, Spenchmak Mado, Giwan Mado. Chimigwach Aki. Chimigwach Nimki Beneshi. Chimigwach Majike. Chimigwach Mashomas Nokumas Wananabajo, Nenwabe, Swabe, Nishodesh, Kakam, Mamagwas, Wanishnabe, Sak. I would like to greet everyone this morning, and I'm of the Bald Eagle Clan, and I'm from Wasauksing First Nation, and I'm Potawatomi, which are the keepers of the fire, and Jamandamuk, which are people with excellent memories. These are the two dialect families of what is known today as the Ojibwe Nation. And my Anishinaabe name translates to one who helps, and our family name translates to one who stands alone. So this morning, I have given some words to creation. And so we talk about how we have good relationships with one another and the importance of having good relationships with all of creation. So we have given our acknowledgments to a being that has created all things. And we also have given our acknowledgments to the earth and to the thunder beings. And we also have given acknowledgments to beings that we describe that are the first beings that have existed. And so we describe them as the Madok. And so they guide us and help us in our relationships with creation. We also give acknowledgments as well to those beings that have gone ahead of us. And so there's many loved ones we think of and friends and family. So we give acknowledgments to all of those beings. So at this time, I would also like to acknowledge as well the team and all of the support here that allows us to do this good work, and really thankful for everyone being able to work together here in such a good way. For us as Anishinaabe people here, there's many relationships that we have here, and this is for us the foundation of them is to have good relationships, good friendships. And this is for us, how do we do that? And so we talk about minal bamazuin, to have a good way of life. So there's many things that we can do to ensure that is possible. So for us, having good communication is one of the major things that we think of. The other aspect that we also think of is this concept of inclusion. And this is something for us as Indigenous people here to Turtle Island. We have done this for thousands and thousands of years. And, our governance models and how we function, we have been doing this for a very long time. So I'm very thankful now, that many organizations have stepped forward, in these types of policies and in these types of directions. It's more important now than ever, and this is something we talk about for, equity and then how we have those relationships. And this is very important to when we talk about Indigenous knowledge. And this is for us when we talk about Indigenous ways of knowing, Indigenous ways of being, that there's many aspects that we talk about for ensuring that data and these types of knowledges are protected in a way for us that where we talk about integrity. And so for us, we have our own frameworks and models that allow us to do that. And I'm very grateful that we've been able to share knowledge today, and that's the desire and the hope that we can be able to do that in a safe way today. We are moving fast, with the age of technology that we haven't seen before, and this is something for us, to move forward in a safe way. We need to make sure that all of these knowledges and systems are working together as well with our principles intact. And I think that's something for us, our ancestors have always spoken about. And to me, that's one of the greatest lessons, hopefully, is one of the outcomes of today. So I'm very grateful to be able to start your day in such a good way. And, I'm really looking forward to hearing a lot of the speakers today, and really hoping that everyone uses this opportunity, to network and, to gather information and hopefully help you, to be able to make a better future for not only us, but also our future generations. So I'll say, Getchi Miigwech, a big thank you, and I'll pass it back to Michael. Thank you.
Thank you so much, Wendy, for setting our day off on a reflective path. So once again, welcome to all of you to the 2023 ICS Research Forum. I'm thrilled to be here with all of you, even if it is virtually, and there are a lot of you. We've had more than 1,000 people who've registered for the conference, which is an all-time record, and I think it really speaks to the power of virtual conferences. We have people who've registered from all 10 provinces in Canada, 2 of the 3 territories, and from 10 different countries around the world. So this is really a great success and great start to the day. Those of you who were in the workshops, I hope you had a great experience. The one that I was part of was really very, very interesting. So, I know you're taking time out of your schedules, and you're all busy people to be with us, to engage with us, and we thank you for that. You're going to hear today from many smart, skilled, and passionate presenters who are committed to improving healthcare outcomes for the people of Ontario and beyond. At this year's symposium, we've brought together some of the brightest minds in health equity and population health data to share their expertise, their lived experience, and their insights. We've tried to design the agenda so that conversations over the next few hours will help us all better grasp the opportunities for innovation in the use of data, research, and analytics to advance a health equity agenda. But we will also be reminded that we need to change how we work with important data relating to equity and engage with and involve equity-deserving communities in the process to ensure the way we work with data reflects the values of those communities. Only in this way can data responsibly advance an equity agenda. We're emerging from the pandemic, an event that laid bare many social factors that drive disparate outcomes. We also saw how data could shine a bright spotlight on inequities and how that, in turn, can lead to positive changes. During the COVID-19 pandemic, studies conducted at ICS and in other institutes and countries rapidly leveraged routinely collected population-level data and led to vital changes in clinical practice that saved lives. Other studies demonstrated vaccine effectiveness and how it varied in higher risk groups and waned. And still others found poorer access to vaccines in higher risk, often racialized communities. These studies led to changes in clinical practice and in the vaccine rollout, which reduced disparities, improved access and uptake in the communities which bore the brunt of the pandemic. The risk as a pandemic recedes is that in this era, with so many critical challenges facing our society, with such rapid change in technology, in data availability, and the leaps forward in artificial intelligence, the risk is that we forget the lessons the pandemic reminded us of so forcefully, and which we really have only begun to learn, and fail to change our health and public health systems in ways which meaningfully address inequities. The theme of this year's research forum emerges from the belief that we can learn, we can partner, we can engage, and we can advance health equity through data. As leaders in this field, we all must embrace change and develop community-informed ways of delivering trusted data and analytics that reduce inequity, improve patient outcomes for all, and increase the sustainability and efficiency of our healthcare systems. For the past 30 years, the ICS community has led high-quality research and analytics that have contributed to improvements in the health outcomes of the people of Ontario and beyond. As we look forward to the next years, we know that the future of healthcare will be driven by much more innovation in data access, analytics, and data science. ICS is committed to being a leader in this future and doing so in a manner that retains health equity as a central focus. ICS is working closely with the Ontario government to expand our ability to link data on social determinants of health in order to better study health equity. And we have also begun to better engage with and involve equity-deserving communities on the journey, because we know this is critical to our mission of improved health and healthcare for everyone. Doing so will help ensure that existing and emerging data and analytic capacity are used responsibly and aligned with the values of the communities the data represents. They must be involved in the design, the implementation, and the knowledge translation. As we move forward, we must commit to dismantling the root causes of health inequities, conducting impactful and responsive research, and working together to harness our full potential as a society. Over the course of today's forum, I encourage you to engage with others, learn from each other, and share your own expertise, your lived experience, and your insights. Let's work together to create a health system that improves health equity through trusted evidence, engaged communities, and better policy and healthcare. Thank you, and I look forward to a productive and inspiring forum. So now I want to just take a moment to thank our key partners and funders who helped make this conference possible, the Ontario Ministry of Health and the Ontario SPOR Support Unit. And also I want to thank our returning sponsor, IQVIA. So now we're going to get into the first panel session. I'm going to remind you some housekeeping that there's going to be a networking break at 12:15 and a lunch break at 12:45. So please plan accordingly. Our first panel is entitled "What Addiction and Mental Health System: The Status Quo and a Way Forward." And the moderator of the panel is Michael Patterson. I'm delighted to introduce Michael. Michael joined ICS as an epidemiologist in 1992 and became an ICS scientist and research program lead in 2008. Currently, he's the chief science officer, the interim chief science officer at ICS, and an assistant professor in the Department of Family Medicine at McMaster University and the Institute of Health Policy, Management, and Evaluation at U of T. Michael, over to you.
Thanks very much, Michael, and welcome everyone. Really pleased to have this opportunity to moderate our first session of the forum today, What Addiction and Mental Health System: The Status Quo and a Way Forward. We'll begin by introducing our panelists. There are more detailed biographies available on the platform. We'll start with just a brief introduction of each of our panel members. Today's session will begin with some introductory comments from Betty Lou Christie. Betty is director of the Support House Center for Innovation in Peer Support. We will then turn to Dr. Paul Kurdiak. Paul is a psychiatrist at the Center for Addiction and Mental Health. He also leads the Mental Health and Addiction Research Program at ICS and serves as Vice President Clinical of the Mental Health and Addiction Center of Excellence at Ontario Health. Finally, we'll turn to Graham Woodward. And Graham also is Vice President of Mental Health and Addictions Center of Excellence at Ontario Health. And then finally, we'll turn back to Betty Lou for some reflections and concluding comments. We will, before the break that Michael mentioned, have some opportunity for discussion and questions. Just a reminder to please use the question tab at the right-hand side of your screen to record those questions. I'll try to moderate those questions as best I can, and hopefully we'll get to as many as possible before the break. So with that, I will turn it over to you, Paul and Betty.
Mike, what I don't know, and I'll turn my camera off, I don't know how to get the content on. Oh, sorry, Betty Lou, do you want to start talking while I do the reload?
Okay, just so we get the slide deck up, I just want to be for transparency to say that I use full scripted notes that I prepare because I'm speaking from lived experience, and that helps with triggers, emotions, timing, everything else. I know it's not quite as interactive when I use the notes, but I think it's better that way. And my internet is doing a weird, so hopefully you'll be able to hear me clearly. We're just going to wait for the deck to come up. So what I will start with as Paul's getting the deck up here is I don't know most of you. I have two roles. I'm actually chair for the Health Minister's Patient and Family Advisory Council. I've been 2 years with Minister Jones and 2 years with Minister Elliott, and reappointed for 3 years with Minister Jones. So I just have to do a disclaimer before we get started. So that would be the next slide, please, Paul. Good. So we'll just get the legal stuff out of the way. I'll presenting in my role as Director of Support House's Center for Innovation and Peer Support. Ideas, opinions, and comments described in these slides and during this presentation are my own and are not representative nor affiliated with the current appointment as Chair of the Health Minister's Patient and Family Advisory Council. Okay, next slide, Paul. So I am honored, absolutely honored to be here today. I really want to have an open and honest dialogue. I want people to feel very comfortable and safe. In order to create safe space, I acknowledge that all of us will approach this in a trauma-informed way. And I promise you when I do my closing part after Paul and Graham present, that I'll end on a positive. I always promise people that I'll end on a positive because the beginning part's not so hot. I'm going to open with a short sharing of mine and my late son Pete's journeys. Uh-oh. Okay, did you guys see that wobble, or is that just at my end?
Just at your end, Betty Lou.
Okay, great. Okay, I'm going to open with a short sharing of mine and my late son's Pete's journey with the intention of humanizing the reality, the complexity, and the collateral damage, trying to negotiate survival in absence of an actual addiction and mental health system. How we fell through the gaps, could not negotiate the silos, the inequitable and structural barrier and stigmas. To be clear, my intention is to provide evidence. It is not to provide judgment. As I share with you, I want you to equate how the family cycles of missed opportunities was a direct result of the fragmentation, the lack of health and social services required to meet our needs. It is my hope in future that data has less emphasis on being a product per se, and more emphasis on data being able to tell a full story, i.e. a client journey. So let's talk. My mother, who experienced serious mental health and addiction concerns, drank while pregnant with my twin sister and myself. My father dealt with a family history of bipolar disorder, schizophrenia, alcohol, and drug addiction. I will share with you that I have had a very long, arduous journey through childhood violence, abuse, and trauma. My resulting cries for help through being a constant runaway landed me in a juvenile detention home, and the trauma continued. Much of that manifested into alcohol and drug addiction and the added complication of bipolar illness, PTSD, crippling anxiety and panic attacks, and anorexia. All of these resulted in many admissions to psychiatric wards, hospitals, bedded addiction treatment over a 20-year trajectory. When I became pregnant with the twins, my heart and hope soared. I was so excited to be a mom. I talked to my belly all the time and promised them that I would be the best mother ever. Then I lost one of the twins in the third trimester of my pregnancy due to domestic violence. The other twin, Pete, survived to be born. That was my catalyst for escaping the violent relationship, but it meant shelter systems, peace bonds, and the constant fear of being found, and the constant fear that Children's Aid Society would take my child away if I could not find housing. Pete was my light in a very dark world. Pete was admitted to sick kids when he was 9 for what schools called behavior and anger issues. The family doctor thought it was seizures. Sick Kids was able to discover that Pete was actually struggling with some serious learning disorders. Pete's mental health was unraveling as he reached teenage years. He self-medicated with alcohol, and within years, that became an addiction. And soon after that came an opioid addiction, along with first episode psychosis. With that, Pete became justice involved. Then I lost Pete when he was 25 years old to an accidental opioid overdose 21 years ago on December 23rd, 2001. Next slide, Paul. That is how he technically died, but in fact, he died from the loss of hope and the pervasive feeling that the world did not care about him, that he was labeled an addict, that it was his fault. No matter what I did, I could not love my son back to wellness or restore his dignity, in large part because I did not have any self-worth myself. That had been stripped from me, too, an indelible stain that was left over from when I, too, was considered and discarded as a useless addict. We were considered to be hard to manage. We were dismissed as non-compliant because of our relapses. We were blamed, shamed, and often told that others who really wanted to get better needed the space that we were taking up. Imagine how that felt. For both my late son and I, the most pervasive and damaging harm was the actual way we were treated. Society dismissed us. Care providers did not want us. Our little family was fighting for survival. We were stuck in a tornado. Pete didn't survive. Next slide. Sadly, I've seen the staggering escalation of opioid deaths since my son's death. To me, as a bereaved mother who watched her haunted son turn into a ghost that nobody seemed to care about, it was incredibly hard to bear witness to the enormous COVID pandemic response while the opioid overdose epidemic continues unabated. A 20-year trajectory of people being trapped in cycles and the continued condemnation of people who are genuinely unwell just not having their needs met. I checked in with our chief coroner, Dr. Dirk Heyer, who by chance was the coroner 21 years ago when my son died and investigated my son's death. So we have a very close relationship from that. He gave me some latest data. So in May of 2021, there was a reported 79% increase in opioid overdoses during COVID. The mortality rate for 2022, Q1 to Q3, and this is preliminary, is just slightly decreased, 14% relative to 2021. However, it still remains higher than the rate in 2019, which is plus 56% increase. Knowing that Pete died in 2001, I asked Dr. Heyer when data started to be collected about opioid overdoses. He mentioned the Ontario Drug Policy Research Network tried to do this around 2010, but the timelier enhanced data collection only began in 2017. Even so, anecdotal informal evidence based on personal experiences was screaming the evolving trajectory of death and harm as far back as 2001 when myself and other people were losing their children. Next slide, please. So this is just one example of a layered inequity and resulting harms from not having a comprehensive and connected mental health and addiction system, and discrepancies between collected data and the trends we are currently seeing and hearing on the ground in real time. No matter how complex, we need to co-design and co-create a healthcare system response that is inclusive and equitable. We all need to feel valued, respected, and treated in a dignified and empowering way. That is what nurtures hope, resiliency, and healing. And now I'm going to pass it back over to Dr. Paul Kurdiak.
Wow, thank you so much, Betty Lou. And for those of you listening in, Betty Lou, when Graham and I and Betty Lou were meeting to talk about this session, Betty Lou's voice is the most important, and you should all know that not only is Betty Lou, working with us today, she's working with us every day. She's a huge support and advocate, champion, and partner in the work that we're doing in our system building. I think what you heard from Betty Lou's story is a complete failure of a system to respond to needs, and a complete experience of neglect by her as a result of this complete failure. To me, that's really when we were talking with the ICS team about data inequity. What I wanted to point out is that data is part of the story, but the fact that there is no mental health and addiction system is a phenomenal equity issue. And I want to put things in perspective. Michael Schull started the session talking about the incredible work during the COVID-19 pandemic, where we saw data being used in near real time to understand on a daily basis how many cases there were, how many hospitalizations, how many ICU deaths, and then bringing in neighborhood variation and being able to respond and do outreach. Incredible success, incredible lessons, incredible work. But why was that possible? And it was possible because there was a wholesale decision to invest in laboratory networks, invest in data systems, invest in data analytics. During the pandemic, I also witnessed a huge focus on mental health and addictions issues that Betty Lou mentioned. But I also witnessed almost no meaningful data, no meaningful investment in the ability to capture data that allowed us to understand the burden of mental illness addictions prior to the pandemic, let alone during the pandemic. This is a huge equity issue, and I'm going to share like a personal story as a contrast. During the pandemic, I had a family member who was diagnosed with colon cancer. And, this was a very stressful, obviously a hugely stressful event for my family. And I used, and I'll tell you why in a second, but I use my privilege because I'm kind of accustomed to the mental health and addiction system. I phoned Andy Smith, who's an acquaintance friend of mine, and said, kind of in a panic, what do I do? And Andy was very, very pleasant, very nice, spent time with me. But at the end of the day, what he said was, there are no guarantees on how you respond to treatment, but there's total guarantee that you will have access to exactly what you need when you need it. And I witnessed this. I went with my family member to the Odette Cancer Clinic and saw, for example, when we registered, and my family member was supposed to go to Clinic A that day, that we sat down, we registered with this little ID badge, and it would say, we apologize, Clinic A is running 2 minutes behind. Well, as somebody who works in the mental health and addiction system, this blew my mind. And I started thinking, in addition to all, how do I support my family member? What is going on that is allowing this to happen? And sorry, you guys still with me? Yeah, so my computer just blanked. Can I get a thumbs up that you can still hear me? Okay, good. So as a provider, and we all have family members who struggle with mental illness and addictions, my experience is so different. I would say on a weekly basis, I have people calling me I have a family member, I have a child who's struggling with mental illness addictions. What do I do? And I don't mind taking these calls at all because I work within this non-system and have been studying this non-system and know what they're struggling with. I have a huge amount of pride for all the providers in the system who are doing their best. I have a huge amount of shame for the system in which we work, because I know how badly we are failing people, and it just has to change. And I'm going to share with you a little bit of data that we've collected that just describes the ways in which this is a non-system, just to put things into perspective. So this is work I did with Therese Stuckel a while back, and what I'm showing you is based on the old lens, the per capita supply of full-time psychiatrists in the province. Not only is there a huge variability in the number of psychiatrists, which determines that you can access, like where you live determines your access, but where the psychiatrists work determine how they work, such that Toronto psychiatrists saw far fewer patients on a yearly basis than psychiatrists in the lower supply regions. And I should also add that this was pitched as a rural-urban problem. It's a supply problem. Mississauga is not rural, but it is a low supply region. The end result is that depending on where you lived, it determined how well you could access psychiatrists, but depending on where psychiatrists live, it determined how they practice, such that overall access is terrible everywhere. So there were a lot of other things we did. We looked at the number of physicians, psychiatrists, and primary care physicians doing psychotherapy, and showed that that we couldn't come close, not even close, to meeting the capacity to provide psychotherapy as a first-line treatment to people with depression, let alone all the other disorders that might be worthy of psychotherapeutic intervention, which is guideline and evidence-based. The other point I would like to make is that this was research we did. The cancer system knows exactly how many oncologists and facilities they have to meet population-based need. To my knowledge, this is the first time anybody looked at how many psychiatrists there were in Ontario, what they were doing, where they were practicing, what the implications were for access. This should not be research, and it's just another sign of the fact that because it had to be researched because there was no system. This map shows two things. One, I'm terrible at graphic design, but it also, what I want you to see is the white and the gray areas are kind of low supply areas, and the red crosses are those areas where more than half of the psychiatrists are close to retirement. Again, nobody knew this until we looked, but there's this whole ring around the GTA where we have psychiatrists who are about to leave the workforce. And there's a huge crisis looming, and nobody knows about it, and therefore you can't plan, you can't mitigate. All signs that there's no one steering the ship, and it's a huge problem. And by the way, I'm focusing on psychiatrists because they're measurable. There's a lot of unmeasurable aspects of the mental health system, a lot of community providers, community agency provision that is currently largely invisible. This is work led by David Rudeler. The point of this was to look at incentives that were designed to improve access for people who had an emerge visit for a suicide attempt. He showed that the incentive had no impact. What I was struck with, in addition to the lack of impact, was that 2 out of 5 individuals who had a suicide attempt severe enough to require emerge attention saw a psychiatrist within 6 months of that suicide attempt. I'll repeat it again. 3 out of 5 people do not have access to psychiatrists 6 months after a suicide attempt. This is I don't even know what to say. This is just a horrific indictment of our ability. And again, providers are amazing. No oversight, nobody's steering the ship, and people are left to fend for themselves and feel completely lost. This is work led by Karen Urbanowski, and this was work we did with Toronto Central Lynn way back when, and it looked at individuals who had multiple emergency department visits. And what I'm showing you is the likelihood to see a psychiatrist within 30 days of the emerge visit for individuals who had 5 visits, but 0 or none of the 5 diagnoses were addictions related, all the way up to 5. And what you can see is, for whatever reason, once somebody has 1 or more diagnoses that are substance related, the likelihood to see a psychiatrist drops by half. I don't know why having a substance use disorder would mean that you are half as likely to see a psychiatrist, because that's certainly not based on need. But again, providers are great. There's no oversight, no quality control, no determination of who should be seen, no system. And the end result is what I see. We have university students having their first depression or anxiety disorder, who, as a result of inability to access care, are knocked off their trajectory, and we suffer from the loss of productivity of people not being able to fulfill their potential because of undiagnosed and untreated mental illness, all the way to what Betty Lou talked about is, people dying with severe mental illnesses. We've done work with people with schizophrenia, where and opioid use disorders and alcohol, I might add, where an inability to access treatment literally causes loss of life at an incredibly early age. So we do what we can with our ICS data, and I should mention that this is about, and Michael Schull will remember this is about the 10-year anniversary of the launch of the Mental Health and Addictions Program. So this is a really momentous occasion. I'm incredibly proud of the work that we've done, because I feel like, in addition to the great work by Betty Lou and individuals like her who are telling their stories with such courage, what we are doing is we are adding quantitative credibility to their stories. We are providing evidence for their anecdote, and it's much, much more powerful, showing exactly the ways in which their experiences are playing out on a population-based level. But we're going to hear from Graham soon, and this is really important. There are things we don't know, and I'm not going to read them out, but we don't know anything about access. We don't measure wait times, and we don't know anything about the quality of the care that's being delivered. And if we don't have those, there's no way we can address system deficiencies. My final note is that that I've talked a lot about the system deficiencies and the problems, but Betty Lou mentioned hope. I'm incredibly hopeful because I feel like we're in the midst of a public mental health moment. The very fact that Betty Lou is working with us is a manifestation of that. The very fact that we are here talking about mental health and addictions issues at an ICS research program, the very fact that there's a mental health and addictions program at ICS, and the very fact that there's a mental health and addictions center of excellence and agency dedicated to creating a system where none exists, to me are all signs of a larger movement. And what I hope is that despite where we're starting from, that there's a long way to go. And I'm going to pass it over to my esteemed colleague Graham, who will show us the way forward before Betty Lou wraps up. Graham, I think you're on mute.
Yeah, so I'm unmuting. You hear me now? Yep. All right, there we are. So thanks, Paul. I'll wait for the slides to come back up. Yeah, so thanks, and thanks, Paul, and thanks, Betty Lou. I have to say again, thanks for such a powerful start to the session. Really brings it home to why this work's so important. So in the next few minutes, I'm going to quickly provide a little bit of background about some of those successful agencies like cancer that Paul mentioned in his remarks, introduce you to the mandate of the Center of Excellence, and then give you a little bit of background on how we're applying the lessons learned from those other successful agencies and applying those to the mental health and addiction sector. Next slide, Paul, please. So for those of you as old as me or older, you'll recall that over the past 3 decades or so, a number of crises have led to calls for and the creation of the agencies that Paul mentioned. And those agencies have resulted in higher quality and more accountable health systems. So examples of that are the Cardiac Care Network, which was created out of a crisis associated with individuals waiting for CABG surgery, stroke care crisis resulting in the Ontario Stroke Network, cancer crisis where individuals were being treated in the United States for radiation therapy, resulting in the creation of Cancer Care Ontario, and as well the need to create an organization for improved renal care, so the Ontario Renal Network. And I've had the great fortune of being able to work as a leader within all of these organizations, and they are all now part of Ontario Health, where I have the privilege with Paul as leading the Center of Excellence for Mental Health and Addictions. So what is it that all of these successful organizations have in common? Next slide, Paul, please. So they all generally follow the same playbook for driving a sustainable, accountable system. And I'm going to spend a little bit of time on this slide and then introduce you to how we're addressing these core elements within the mental health and addiction sector. So first, at the top left, the first step is really identifying who's accountable for care. So we need to understand who we expect to deliver care and what outcomes we expect to see from that care. And that takes us down to the next item, which is essentially, well, what standardized evidence-based care do we expect to be delivered for a certain condition? And that needs to be clear and it needs to be effectively communicated to providers. The third aspect of it, now that we know who's accountable for care and what care we want to deliver, is we actually need to monitor the system to make sure that's what's happening. So we need to know that the care we expect to receive is being received and that we're achieving the outcomes we expect to see from the evidence. So that's a little bit on the left-hand side about the what we need to have in place in terms of an effective system. The right-hand side is a little bit about the how. So the top is about who informs change. And I actually find this is an aspect of it incredibly important to the sector we're talking about today, but highly neglected. It's the idea that we need to engage the people with the greatest experience in the system to help us redesign and monitor that system. So in this context of that, it's individuals who provide care and individuals who receive care and their families. So it's critical that we, on a regular basis, ongoing engagement of those folks for redesign. And no surprise for individuals in this call, the need for sound data and digital infrastructure to collect that data so we can make sound decisions and monitor those decisions over time. And lastly, at the bottom of this, really we need to think through a system that allows people to quickly access the system and navigate their way through the system, things we know are very absent within mental health and addictions. Next slide, Paul, please. So a little bit of history repeating itself when we think about those agencies that were created in the moment of crisis. So, back in the late end of the last decade, as a result of growing concern about the mental health and addiction sector, in 2019, our government introduced legislation to create the Mental Health and Addiction Center of Excellence. In 2020, that legislation was proclaimed, and so the Center of Excellence was created within Ontario Health. Soon after that, our government also released their strategic plan for mental health and addictions called the Roadmap to Wellness. And then, as you all recall, very soon after that, the pandemic hit, and Betty's made reference to this, so has Paul. And for all intents and purposes, development of the Center of Excellence paused as we all turned our collective attention towards the pandemic. It's only been over the last 18 to 12 months that we've actually begun to, as we come out of COVID, turn our attention back to the creation of the Center of Excellence. And so I'm going to walk you through a bit of the progress. So next slide, Paul, please. So briefly, what is the Center of Excellence? So it is the agency that's been created in Ontario to build a comprehensive and connected mental health and addiction system. We play a critical role overseeing delivery and quality of mental health and addiction services and supports. We work very closely with our ministry colleagues to implement key priorities within their Roadmap to Wellness. And within that Roadmap to Wellness, as well as legislation, we are directed to implement the lessons learned through those successful agencies like Cancer Care Ontario. So we need to follow that playbook. Next slide, please. So when we overlay that playbook on the mental health and addiction sector, probably no surprise to many of the people here, this is what we find. We don't find much of those core elements in place. We don't see a lot of accountability. There is a lack of standardization of services across the sector. There is very limited monitoring of performance. We don't see regular engagement of providers and those persons with lived experience in redesigning the system. Poor data and poor data collection infrastructure, and as well for the unfortunate individuals who need access to this system, it is incredibly difficult to access and even more difficult to navigate once you're in. So kind of what do we do about that? That is the role of the Center of Excellence, is to actually put in place these core elements. And as Paul has articulated, it would be impossible to imagine equity in a system with all these core elements missing. Next slide, Paul, please. So what does this mean for the Mental Health and Addictions Center of Excellence and for care across the province? Hopefully in the short term, it really means a push towards greater standardization and equity. So beginning to answer that question about what care people deserve regardless of where they seek care. Huge push on data and measurement so we know we're delivering the care people need, where they need it. And a big focus on transparency and accountability so we can promote high quality care when we see it and drive better outcomes. Next slide, Paul, please. So in terms of the characteristics of the system we're moving forward with, how will we know it when we see it? Because we're going to need to monitor that system even before we see changes in client outcomes. So if you look at the left-hand side of this slide, this would be the current state for mental health and addiction system, where in the best case scenario, providers are monitoring the services they deliver and the quality and outcomes of those services. But we really very quickly need to move into the center of this slide, which is where we see quality monitored and reported provincially. We see system-wide collaboration on quality and standards. We see the adoption in a systematic and standardized fashion of scientific evidence and clinical expert consensus. And we see strong data and a strong digital backbone. I won't get into the side on the right. This is where we'd find cancer and cardiac and other systems, but it's where we need to go eventually. But we do need to focus very quickly on the center of this slide. Next slide, Paul. So now I'm just going to very quickly try to walk you through where we're at with respect to the Center of Excellence and those core elements. The first element I'm addressing is that stakeholder engagement component. It's a very busy slide. Obviously, if anybody wants these, I'm happy to send them along. But what it articulates is we are now on a regular basis articulating providers and persons with lived experience on the left-hand side of the slide to define and monitor good evidence-based care. So what does quality look like when we see it? How would we measure it? On the right-hand side of the slide, we're also engaging individuals, providers, and persons with lived experience on helping us redesign the system. So both at a provincial level and a regional level, helping us, advising us and monitoring on system planning, resource allocation, and coordination of services. This is a big step forward for the system, and it's something that we've put in place this year. Next slide, please. So when we get into that element of data and digital, we've, I think, touched on this already. We see only siloed data with no central repositories that are accessible for planning and funding and performance, or an inability to map the client through the journey, inadequate data management and IT capacity, and a lack of standardized data. Next slide, please. So to address that, and it's early days for us, but we have put in place, in partnership with providers and the regions, a point of care data collection system for community-based providers that is now on a regular basis, nightly, extracting data from their systems and moving data into a central repository, which is represented in the center of this slide. And in that central repository, we marry that data with existing data sets that many of you are probably familiar with, such as the DAD, NACRS, OMERS, OHIP billing data, as well as some very specific data sets collected by CAMH that represent services being delivered in Ontario structured psychotherapy, as well as community addiction clinics. And we then use that much more robust data to better inform planning, funding, and monitoring of services. And over time, we'll incorporate that data into an electronic health record to inform client care. Next slide, please. So the remaining slides, there's only a few left, bear with me. I'm just going to focus on some of those evidence-based services and how we're applying the programmatic approach to drive more standardized, improved care across the province. And I'm going to zero in on depression and anxiety-related disorders and a specific service of Ontario Structured Psychotherapy Program. So you'll see here there's a number of different services we're focusing in on for the treatment of depression and anxiety-related disorders. But for psychotherapy, we now have a standardized approach across the province for all individuals in need of care. And then the next question becomes, once we've adopted a standardized approach for services, how are we going to deliver those services in an accessible, equitable manner? So next slide, please. So using evidence-based planning approach, we've actually expanded the number of access sites for services across the provinces. We've actually done this using a hub and spoke model, where we've gone from 4 to 10 network lead organizations. And each one of these hubs or network lead organizations then creates contracts with multiple service provider sites across the province. So we now have over 100 service delivery sites delivering consistent structured psychotherapy for individuals in need across the province. Next slide, please. And so how do we ensure that those providers are delivering the services and achieving the outcomes that we want to see? So this is where we get into the program or performance aspect of one of those essential elements. And it's through a series of contracts and discussions with providers. So that the Center of Excellence engages in structured contracts with those network lead organizations. Within those contracts are expectations in terms of service delivery and quality. And we regularly meet with the network lead organizations to discuss how progress and strategies for improvement, as well as sharing successes. The NLOs, in turn, have similar contracts with the service delivery sites, where they have engagement and contractual obligations in terms of services delivered and outcomes achieved. Last slide coming. Next slide, Paul, please. So this slide summarizes then the information we use to track that progress and inform those performance conversations with the NLOs. So you see at the top, this is a dashboard. It begins to tell us in almost real time how many clients are referred into the system, how many clients are then subsequently enrolled into the system, how long those individuals wait for referral, enrollment, and treatment, and then begins to track the outcomes of care for individuals that move through that system. So I know it's been quick, but I hope through these quick slides, you're giving a sense of the activities underway to try to address the huge disparities and equities that currently exist within our mental health and addiction system. And at this point, I'm going to pass it back over to Betty Lou to take it home.
My connection is down to a red dot, so can you hear me okay? Paul, can you wave if you can hear me okay? Okay, so if for some reason you can't hear me, just wave back again. Okay, I'm going to speak to you now about the importance of meaningful engagement, partnership, and co-design with lived living experience, patient, client, resident, citizen, family, caregiver, however each of us identify. But first, I'd like to quickly tie in Graham's piece from my own experience, Another Chance to Humanize. My partner, a perfectly healthy person, went to work in 2015, had a heart attack, spent a month in hospital to stabilize, and then a quadruple bypass. Next, he developed COPD, a combination of some bacteria that permanently destroyed the pleural lining of his lungs and his exposure in a paint shop. Next, he was diagnosed late due to COVID with a stage 4 incurable, untreatable metastasized cancer. Obviously, this has been really hard to negotiate, but his health journey has been exemplary due to the systems approach that has established clinical pathways, comprehensive connected care, informed choice, compassionate care, and constant, effective, and responsive follow-up as we negotiate the coordination of 3 complex health conditions and the peaks and valleys that come with this trajectory. This includes coordination of cardiologists, urologists, respirologists, several oncologists, and 5 different hospitals. Not once was he lost in a gap or a silo. Not once did he face structural barriers or stigma. Not once was he minimized, rejected, devalued, questioned, or pushed into a rabbit hole of indifference. He had a completely different experience with healthcare than both my late son and I had. And that is why I'm so excited about working with the Center of Excellence and the pathway they're on, because there's solutions in there. I know it's there. Which brings me to engagement, partnership, and co-design. There is a growing essential role for people who have engaged with healthcare services to share their life journeys and transferable skill sets to help guide our discussions toward healthcare transformation. Patient client, lived experience, family caregiver, residents, citizen voices are essential links to drive meaningful change. A large piece of this goes well beyond healthcare parameters and is more about social change. It's where healthcare intersects with the broader social determinants of health and what people need to find their wellness, whatever that looks like for each and every one of us. Experiential expertise can have an enormous positive impact across the continuum of care by providing a broader perspective grounded in the reality of what truly happens to people, both good and not so good. The nexus of change all throughout history as being those people who can speak up and speak out in meaningful and effective ways. Quality is reminding people that we need to broaden our scope of what experts and expertise is. We also need to embrace living experience as another stream of evidence. People with lived and living experience have been taking care of themselves in absence of a system that works for them for forever. No one is better positioned than we are to work hand in hand to co-create what is needed. Those with lived living experience, patients, clients, residents, families, caregivers, have helped to shape healthcare transformation in Ontario, and we continue to do so in new ways with authenticity and intentionality. The lived experience of people, patients, families, and caregivers is shaping the cultural shift from storytelling to evidence. This provides a roadmap to affirmative change. While recovery from the pandemic is underway, health system transformation is happening at exactly the same time. These 2 factors have proven to be a galvanizing force, surfacing the health disparities and inequities for people who face barriers. It's time for a necessary cultural evolution in healthcare. There are tangible results and important collective impacts when true partnership, engagement, and co-design with lived living experience, patient, clients, families, caregivers, residents, citizens are at the center of healthcare system planning. Together, we can co-create a learning and improvement culture. Within those parameters, we can co-create brave space and allyship with an increased focus on diversity, equity, anti-racism, accessibility, reconciliation, and inclusion. It's more important now than ever on the ongoing impacts. And to close, I'll just list a few key factors that are instrumental for the success of this. Recognizing and respecting that patients, families, and caregivers as partners and including them at all stages of planning, design, and implementation. Actively engaging patients, families, and caregivers living experience with diverse perspectives and lived experiences, and actually engaging those who are equity deserving and vulnerable. Considering and addressing barriers, equitable participation. Ensuring the engagement of patients, families, caregivers, living experience happens frequently, respectfully, meaningfully across all areas of the healthcare system. Providing patients, families, caregivers, lived experience, citizen residents with ongoing support such as tools and resources and honorariums. Ensuring that all partners in the co-design process have the appropriate skill sets and opportunities for training to participate meaningfully. These partners include patient, family, caregiver advisors, health system leaders, and healthcare providers. So together, I honestly do believe that we can rebuild and co-create solutions. Together, we can demonstrate the art of possibility. Be curious, humanize, innovate, and emerge. Thank you.
Thank you to all of you for painting such a compelling picture for us and call to action. We do have a few minutes left before our break to respond to the many questions that have come forward. Thank you very much to those of you who have contributed questions today. Maybe I'll just present some of these to the entire panel, and feel free to respond if you can. So at the top, we have a question about the importance of race-based data and socioeconomic status information in the work that you're doing. Are you able to comment at all about the importance of those data sources and our ability to bring them to bear on the work that you're doing?
Sure, I can be really quick. We have established a standardized provincial data set that incorporates sociodemographic data that have been formed by all sorts of engagement, including race-based and other equity-oriented sociodemographic characteristics that goes well beyond what we have routinely. And we aim to leverage those data. And the standardized provincial data set is intended to be collected at a point of contact throughout the entire system. So we should, this is really important for us to be able to monitor equity-related outcomes using data so that we can be transparent and accountable in ways that we know the system is not working.
Thanks, Paul.
And I'll add one thing to that, Paul, because it's something we've heard back from providers in their collection of data, because that's typically where it comes from, is the need for tools and education to better equip them to do the collection. People struggle with asking these questions and explaining why they're asking the questions, and we need to better equip them with that. So this whole problem takes a whole system to help fix, and so I'm just putting those out there because people can help us think through what are those tools and how do we equip providers to do the data collection in a much better way.
Thanks, Graham. I've just received a note that we are awarded a few more minutes so we can continue into the break, which is terrific. Thank you, Naveen. So the next question up actually builds on some of the work that you've done previously, Paul, around psychiatrist supply, and comments on the rise in youth addictions and suicide, and whether or not the trends that you're seeing more generally apply to psychiatrists who specialize in the treatment of youth. Is that the case, Paul?
So we've been seeing some troubling, and that's from Teresa Toe, who would know the data as well as I. We've been seeing some really troubling trends in the transitional age youth category for some time now. It predated the pandemic and likely got worse it did get worse during the pandemic. And even in younger age groups, 10 to 13-year-olds, there was a dramatic rise in emerge visits for suicide, which is horrific to think about, 10 to 13-year-olds. The truth is that we do not have a good way of measuring child psychiatrists within our data. So I actually have a PhD student whose whole thesis is coming up with the definition, validating it, figuring out where they live and how they work. And I am guessing it's like work we've done in the geriatric psychiatric side of things, is that they're going to be even more concentrated in urban areas than than all of psychiatrists, because they're typically attached to academic centers, and less likely to be sitting out on their own in community settings because there are far fewer of them. And I also think there's going to be some eye-opening aspects in related to models of care, because I think child psychiatrists have a way of practicing that they do a lot. Like, they tend to do a lot of intensive work, which gets to the bigger issue. This isn't about what psychiatrists are doing or not doing. There's a huge, and Teresa would know this as well, there's a huge network of agencies focused on child and youth mental health and addictions. There's primary care, there are pediatricians, but the point is that the right hand doesn't know what the left hand's doing. There's gaps and overlap everywhere. And so, sure, I think we need to figure out what psychiatrists are doing, but the bigger question is, what is the role of child psychiatrist in a properly organized and coordinated mental health system that serves child and youth mental health needs? And that's really where we need to get to go. We need to get going, because I saw a question below about what about private services. A lot of children have to pay for services if they happen to have families who can afford it, because the services are virtually inaccessible for their needs. So I'm taking that one, what's happening with child psychiatrists, and using the opportunity to say there's a huge amount of work to be done on the child and youth side in terms of system building that has been even more neglected than on the adult side. Huge silos and huge issues.
Thanks, Paul. Maybe I'll just pick up on another question here regarding physician supply. And someone was asking about whether or not there are any incentives in the system to promote medical students seeking psychiatry as a subspecialty.
So I can only comment on the U of T Department of Psychiatry. When I was in medical school at U of T, becoming a psychiatrist was highly stigmatized, right? Like, it was considered a professional choice of why would you do that? That was the question I had. What, psychiatry? Like, why would you do that? Why would you? It was kind of like a waste of talent, or which I found, hard and mind-boggling. Things have changed. We have unfilled. We don't have any unfilled positions in the Department of Psychiatry. It's actually becoming competitive. I think the reasons for that are complicated. I think there's a shift in like lifestyle and choices. But I think part of the issue that psychiatry is becoming more popular is because of this public mental health moment. I think that millennials are far less stigmatized about mental illness and addictions issues than my generation, and are not burdened by the stigma, and are much freer to consider professional choices. So I don't think it's an incentive problem. I think this is a stigma problem, and I think it's kind of fixing itself, but I could be wrong.
Thanks. That's terrific. So a question here for Graham. Graham, in your point of care data collection system, are you making room for any qualitative information, qualitative primary data collection? Any mechanisms for that?
Maybe I saw another question about what kind of data and those types of things. So maybe I'll answer that in this way, because I'm not quite sure the person asking questions what they're referring to in terms of qualitative data. I'll start with the lack of data for me coming from the sectors I came from previously, incredibly striking. Like, we lack the most basic information in terms of the numbers of individuals who are actually accessing care in community services. Right. So the hospital system, yes, but those are the individuals who unfortunately are the most severe. And even in those cases, we don't understand the care they've received previously. We don't understand their history. And so we truly need some basic information about individuals who are in the system right now. This $4 billion system that our government funds, for the most part, we don't know who's receiving care and the services they're receiving, much less some of the qualitative information surrounding those individuals. Maybe I'm noticing that, we haven't invited Betty into the conversation, but Betty might be able to speak better a bit to some of the qualitative information she'd hope we would collect perhaps out of that system. But we're in the early days of just trying to get a rudimentary data system in place.
Yeah, I think my very short answer to that is I always find it interesting when we're rolling up our data for EMS or reporting to our funders. And it's more like widgets and counting beans and butts in the seats. And that's basically what it is. The numbers, the reporting, it means absolutely nothing. And I think that's the most frustrating part to me. I work in healthcare now too, so it's basically like I see this a whole other side, and it's really, how do we get that balance of qualitative, quantitative? How do we actually get the numbers to speak in a humanizing way, but speak to the value of like 20 people in a seat is one thing, 40 people in a seat, but what if those 20 people actually need wraparound services because there's so much complexity that surrounds them, so many things that they need. So therefore a worker wants to spend way much time with that, and the system doesn't allow that. So that's just basically my short thing, is that we got to stop counting widgets.
Thanks very much, Betty Lou. I think that's a good place to stop, actually. And maybe I just want to take this opportunity to thank everybody for your contributions to today's session. Wonderful session, compelling story and call to action for us, and terrific to see the progress that we're beginning to make. So maybe at this point, I'll just turn it back to Michael to transition us into our break.
I'm not sure if people can hear me. Oh, there I am. Okay, great. Okay. All right. Well, listen, thank you to Mike Patterson, the moderator, and the panelists. That was a really terrific way to kick off the forum. Deeply moving. And thank you, Betty Lou, for sharing your stories with us, and also Paul. So we're going to take a quick break now. We're going to come back at 12:30 p.m. sharp. I'll just want you to know that at 12:30 p.m. we'll be introducing a keynote speaker, the Deputy Premier and Minister of Health of Ontario, Sylvia Jones. So please be back here at 12:30 sharp. We'll also, by the way, be taking a lunch break at 12:45 p.m. So just to remind you of that. So we'll say goodbye for now and come on back at 12:30.